2017. Our local organization works to effect change through awareness of issues, to take action at all levels of our democracy. We meet weekly in Del Mar, and we are open to all, both men and women. Our members are from Albany, Guilderland, and many other communities in the area. If you're interested in our group, please leave your email on one of our sign-in boards in the back. Or you can just drop in on Wednesday mornings at 9:30. We're almost always there unless it's a big holiday. And we meet at Brugger's in the community room. So if a lot of people come, we pack ourselves in there. Tonight we have joined with the Capital Region Chapter of Physicians for a National Health Program, the Capital District Alliance for Universal Health Care, and the League of Women Voters of Albany County to bring you information on this critical topic. Medicare for All, our town, our taxes. You may have heard the terms Medicare for All, Single-Payer Health Insurance, Universal Health Care, and generally they describe the same idea. Clearly there is some concern about the cost of such a program. Tonight we will look at the data and see that what Medicare for All might be in our community. We are lucky to have Dr. Andrew Coates in the Albany area. He received his medical degree from Columbia University and completed his residency at Bassett Hospital in Cooperstown. He practices internal medicine at Albany Medical College. In the Albany area, and is assistant professor of medicine and psychiatry at Albany Medical College. Dr. Coates is a co-founder of Singlepayer New York, and in 2013 he was elected president of Physicians for a National Health Program. It is a nonprofit research, educational organization of 20,000 physicians, medical students, and health professionals who support single-payer national health insurance. Tonight, Dr. Coates is joined by Dr. George Jolly, a retired physician from Middle Grove, New York. His medical degree is from Temple University, and he completed his residency there as well. He has been board certified in internal medicine and geriatrics. And like Dr. Coates, Dr. Jolly has been a longtime member of Physicians for a National Health Program and is active with the Saratoga healthcare community. He is retired from 36 years of practice. We will begin with a presentation by the speakers, which will be followed by questions from the audience. Please hold your questions until the question and answer portion of the program. So now, please welcome Dr. Andrew Coates and Dr. George Jolly.
Can everybody hear me very well? No? I've got to get close. Maybe that's... Is there? Okay. Thank you for including us in this discussion. You got it? Should know up front that we're both of us quite biased, though. That is, we've both been very long-time supporters of the single-payer health care finance. Now, I'm going to argue just a tiny bit with Tony here, because she said that the single-payer and universal health care are almost the same thing. Well, it turns out they're not. That universal health care means everybody's covered. Right? But there's several different ways that you can achieve that. Single payer turns out to be one of them. And around the world, there's a few places where there's nearly a pure single payer system that achieves the universal health care. But most of the systems are mixed systems. So if you look at a place like Switzerland or England, there are different models that are mixed together. Now, I'm not going to go into the details of that, but I do want to make sure that everybody is talking about it's fairly easy to agree that, gee, everybody should be covered by health insurance. That sounds to me like there shouldn't be any question about that. But, and the question that we really then have to decide is, well, how are we going to accomplish that? And what would this, and we're here tonight to talk about why our present mixed system here in the United States is not working so well, and how a single-payer finance system would bring us to that point in a better way. Now, I want to sort of give you an idea where I'm coming from as to why I favor single-payer finance. We make our decisions about what's important to us in life based on stuff we learn pretty early in general. And when we're trying to evaluate public policy of one sort or another, I fall back on some very simple rules. The first thing is it fair? And the second rule that I want to test the policy against is it thrifty? Now, where did I come up with those simple things? Well, when I was a kid, my mother, in solving disputes between me and my 5 siblings, taught me that if you follow the golden rule, you'll almost always get your behavior correct. If you follow the golden rule. Basically, I was required to consider how I would feel if I were in another person's situation. The second thing is the thriftiness. I teased my father about being cheap all the time. But what really bothered him was waste. He was willing to pay for what he considered to be a good value. Value means you get a lot of a good thing for a relatively low price. And one of the things we're talking about here is value in our healthcare system. Are we getting what we want for a reasonable price? So put in those terms, single payer seems like a really no-brainer. There's no question of eligibility. Everyone's included. The most vulnerable of our citizens are automatically, as well as the most affluent. Illness is a difficult thing to negotiate without fighting with an insurance company or experiencing bankruptcy. Reducing the number of payers in the system to just one decreases the complexity of paperwork. There's only one set of forms. There's only one set of prices. There's only one credentialing process, among other things. Additional strategies like negotiating the prices of drugs and medical supplies and appliances, and using global budgeting for hospitals can help move us toward getting our money's worth. And those are all part of the single-payer idea. I have particular trouble with anyone with a for-profit healthcare company. Because I don't think that our healthcare system, my healthcare dollar, should be anybody's cash cow. I just feel so strongly about that. But don't think for a minute that healthcare is going to be cheap. Technologies and medications are life-saving, but they're also costly. The question, though, and I want to ask you, and I'm going to ask you again as we go along, why do Americans tolerate paying twice for health care per person what other industrialized democracies do, but we get inferior results, inferior outcomes? I'm going to make a jump here. I want you to think that what a single-payer health care would feel like to the residents of Del Mar here and of the town of Bethlehem and in the larger in Albany County. So as a patient under the single-payer health care, you'll have a card. And when you go to the doctor, you present your card. You've made that appointment with a doctor of your choice, whoever you wanted to go to. No limits on who you call up for an appointment. A checkup, there'll be no deductibles and no copays. When you go to the pharmacy, similarly, you'll show your card and get your medicine. When your new baby is born, she will get a card, she'll receive a card too. And her care at the doctor's office will be similar. As a tax-paying citizen, you may be pleased to find that your property taxes, both at the county and the school, have been reduced because of reduction in the cost of healthcare expenses to the county. Be sure to look at your sheets on your chairs and my little posters, repeat those. It gives you the idea of what your local governments would say if a single payer system is in operation. The potential for savings are dramatic. How are those Albany legislators going to figure out what to do with an extra $105 million? If you're an employer, if you've already committed to providing health care for your employees, you'll see costs reduced. If you have felt you couldn't provide health care because it was too expensive, it'll now be available at a reasonable cost. You'll know that your employees and your own family will be getting the protection they need, and a quality of a health care plan that's as good or better than what's currently being offered to New York State employees now. As an employee, you'll no longer see modest increases in wages eaten up by out-of-pocket expense rises. You'll have real security in that if you get too sick to work, you and your family won't lose your insurance. You'll know that if the job you're in turns out not to be such a great fit, that you can actually quit, start your own business, or get a job somewhere else without losing your health care, and for you and your family. If you're a health care provider, you can expect to get back much of those hours every week that you're now forced to engage with the insurance system in our country. You'll be able to spend more time with your patients, and you may choose to reduce your billing and administrative staff. If you're a town board or school board member or a county supervisor, as I said, you'll have the difficult task of figuring what to do with a lot of extra money. You may be able to reduce taxes. You may be able to provide services that were neglected before. You won't have to argue with your unions about health care and dental benefits. You and your employees will all be covered with an excellent quality plan. You can have some relief knowing that your employees are not having their modest increases in wages eaten up by rising costs. So, these are the things I want you to think about. And I want you to ask yourself, what would it feel like here in Mifflin, County in Belmont? What would it feel like to have single-payer health care? You know what would it feel like? It would feel like a lot less stress. Okay, now, you know this guy. I'm going to turn this over to Andy Coates. Both of us don't just want to talk. We want to hear what your concerns are. But I'm going to let Andy go first and introduce himself, and then we want to go right to questions.
Can the folks in the back Can the folks in the back hear? Can you hear the speaker?
Yes. Can you hear us?
Barely.
Not
Hello?
well, okay.
Oh, you're going to hear me now.
All right. So if you can't hear me, let me know. Both of us relish the questions because we could talk about the details of policy that we're interested in, and it might not meet your needs. And I think that dialogue is what we are really after. And so I'm going to try to be incredibly brief, but I mean, the idea, George laid out this idea that maybe in the modern world, medical care is a necessity that is a public responsibility, and that any nation that would claim to be a democracy that wants to protect its citizens in an equal way would make sure that everyone had access to all necessary health care as a part of modern life. And that's not saying that health care is a human right, which I passionately believe. What I'm saying is that the fact of life is that health care is a modern necessity, and it should be the responsibility of the government to make sure that everyone has access to all the necessary care that we need. And the role of the government should be to protect our decisions so that our decisions about our own health are made with the caregiver that we choose, and that our decisions stay within medical science, and that those decisions then are enacted without cost because of the illness. So I work in the hospitals. I thought the most useful introduction might be a little bit of sharing about myself. I graduated from medical school in 2002. I like to say that I'm an old man, but a young doctor. Before medical school, I grew up here in, just south of the Albany County line, like 1 mile south of the Albany County line. So, you know, I got my first speeding ticket right here at 32. Since medical school, I've been shocked that our system would organize itself for indignity, for absolutely organized to make undignified care when people are in their greatest need. That our system would leave people out completely. You know, I have a friend who was living in Binghamton in a poor neighborhood, and he was trying to describe to me his observations about his neighborhood. And he said something that was really striking to me. He said, "All of my neighbors limp." So in Canada, there's a big scandal about wait times to get to elective orthopedic surgery. In Binghamton, everybody in my friend's neighborhood limps. Are we measuring their wait times to get to elective orthopedic surgery? Are those patients going to orthopedic clinic? Are those patients going to physical therapy? These are poor people in our country who are assigned to limp for the rest of their lives rather than seek health care. This is routine. I thought the insight was very pedestrian, and yet, I guess that's kind of a pun, but I thought the insight was tremendous on his part about people who are left out. The other thing that happens in our country is incredible injustice, shocking injustice. There are oodles of studies about disparities in healthcare. The proper word is racism. African Americans who have real big health needs are less likely, all the way down the line, all kinds of procedures, all kinds of technology, all kinds of whiz-bang stuff that we do every day, they're less likely to get there. And it's a study of healthcare disparities. Women pay more for every aspect of healthcare. There's disparities between women and men. And lately, I think this is this week in the New England, in the American Journal of Public Health, forgive me, there's a study that shows that since the Obama reform has invited all of these copays and high deductibles, that healthcare by itself has worsened income inequality because of health costs on the poor, because the poor now have out-of-pocket costs that are staggering. So it's arguable that rather than making things more equal, according to these authors in the current American Journal of Public Health, the health reforms have made things less equal. And this is when so many times in history, healthcare, the provision of healthcare, was a way to ameliorate some of the pain of poverty. And I see this in my daily practice. I don't think there's a single patient that I discharge from the hospital where money, naked money interest, money for co-pays, money for which facility, which rehab, which, I don't think there's a, if you look at every case, I don't think there's a single one where those things aren't intervened. And then I've had some shocking cases lately. I discharged a man with a brain tumor, and he was elderly. His children were great. He lived with his daughter. And they decided that really there wouldn't be good sense in having treatments, and he was going to invite hospice to come to his house. And we sat down at the discharge meeting, the students and I, to just make sure that the whole family was comfortable with really the decisions that everyone had made. And the children revealed to me that for over a year, brain scanning had been denied by his managed Medicare company. That his cardiologist had tried to order a brain scan, that his primary care doctor had tried to order a brain scan, and it had been denied, and it had been appealed, and had been denied. And so his children were just haunted by this idea that they hadn't, that it was somehow their fault, that they had not fought hard enough for the brain scan that might have detected the tumor a year earlier. And I reflected that in terms of our system, this is very commonplace, but when it comes to managing Medicare, Medicare is a public entitlement, it's a public benefit. And if this man had had traditional Medicare and had not enrolled in a managed Medicare company, he would not have had that level of review, trying to cheat and count every penny. And so it was sort of a funny modern injustice where, because of managed Medicare, which is when the insurance company gets money from the government plus about, I believe the statistic is 11 to 16% extra per patient. So they're guaranteeing the profit. And then to double guarantee the profit, they try to cheat the patients out of necessary care. That wouldn't have existed if you had traditional Medicare, even in our system. And so when you reflect on those in the evening, you know, the sense of injustice is really, really compelling. And I think that that's why I've become so motivated, because of my experience. So I've been thinking about like this as a struggle, and I wanted to share with you a little bit of thinking about that. In 1857, Frederick Douglass gave a speech in Canandaigua. You know, he's an upstate New York guy, right? It was called West India Emancipation, and it's often quoted for this exact passage. And Douglass said, "Let me give you a word about the philosophy of reform. The whole history of the progress of human liberty shows that all concessions yet made to her august claims have been born of earnest struggle." And what I take from that is that if we don't mobilize millions of people, we will not have a fair healthcare system in our country. The conflict has been exciting, agitating, all-absorbing, and for the time being, putting all other tumults to silence. Well, it's hard to silence. It's very hard to compete with the struggle against slavery. What an incredible, titanic struggle. And many, many, like Douglass, knew the stakes and what it would actually take. But in terms of the philosophy of reform, he's talking, it must do this or it does nothing. If there is no struggle, there is no progress. Those who profess to favor freedom and yet deprecate agitation are men who want crops without plowing up the ground. They want rain without thunder and lightning. They want the ocean without the awful roar of its many waters. And after 15 years of activism against the healthcare establishment, the insurance companies, and the most lucrative part of Wall Street, the pharmaceuticals, and now finance capital running our nursing homes, which I find shocking, for-profit business of all types, we are really up against a serious foe if we want to have a dignified system. So Douglass went on, this struggle may be a moral one, it may be a physical one, and it may be both moral and physical, but it must be a struggle. Power concedes nothing without a demand. And what a beautiful demand to say that every human being who needs health care should get it. That is a powerful demand. That is a beautiful demand, right? That is what we should all be about. It never did, he says, power concedes nothing without a demand. It never did and it never will. Find out just what any people will quietly submit to and you have found out the exact measure of injustice and wrong which will be imposed upon them. And these will continue till they are resisted with either words or blows or with both. And I cannot believe some of the incredible indignities have been heaped upon my patients. A poor man whose mother needed rehab but had managed Medicare and had a $300 per day copay for the managed Medicare. And obviously, he did not have $300 in his savings account. And he said, my mother will get rehab because it's what she needs, and don't talk to me about the money, I will find it. He would remortgage his house, he would sell his car, he would do whatever he needed to do proudly, as if it was his personal responsibility in this crazy game where if she had had traditional Medicare, there would have been no copay. And I tried to talk to him about it, and he wouldn't talk to me about it. I had a patient recently who had a very bad end-of-life experience. And their attitude was, well, you can't fight City Hall. And I was shocked that they would be so willing to take their lumps, if you will. I remember researching there was an annual payment plan at Cooperstown in the 1930s. It was an experimental food practice where people paid one lump sum and they could come as much as they wanted after they paid it. And it was successful. And I researched it. And the board of directors of the hospital kept a letter from a farm woman who had had a hospitalization and paid cash out of her milk check a few cents a month for 10 years because she proudly paid off her medical bill. And this is why in the United States, the leading cause of bankruptcy is medical bills. People pay them. We don't go on strike. We don't say, hey, that's ridiculous. I didn't choose to get cancer. We don't say that. We say, oh, my responsibility is the medical bill. We take our lumps. Or as Frederick Douglass said it, forgive this device, find out just what any people will quietly submit to. The injustices are shocking. So he says, the limits of tyrants are prescribed by the endurance of those whom they oppress. And I think that there's a certain kind of ideology that we deserve our sickness. What did I do wrong, Doc? It happens to me almost every day. I was shocked. Do human beings choose to become sick? Do human beings deserve help when they want to become healthy? I mean, these are obvious facts of modern life. There's great technology, so I'm very motivated by this. And then I just add one more thing. It's great to talk about the morality, which I'm obviously doing. There are marvelous faith-based activists who believe that every human being should have the same dignity because of their faith in their God. And then there are great legal cases to be made that we should have equal protection under the law and equal access. What Physicians for National Health Program is trying to bring is something else. What we're trying to bring is social science. Science. And that's why George mentioned some esoteric things like global budgeting for hospitals. Well, this is how we actually save the money to make public planning. There should be no copays and no deductibles, no cash on the barrelhead when you get care, because studies have shown for decades that patients who have to pay for care avoid necessary care because of the money. And obviously there should be no profits. And the reason for that, although it's abhorrent to think that one human being would take advantage of another person's illness to make a profit and gouge them, that's shocking morally. In health policy terms, it's just stupid policy. It creates more deadly care at a higher price. It's just stupid policy. And so from the point of view of health policy, what we need to do is think about public service and a public health service. And the minimum step forward would be to abolish private health insurance and have all the payment coming through the public. So now I've spoken too long, but we'd like to take questions. Thank you very much. This will help everyone.
Thank you very much. My name is Brendan Mooney. My wife had multiple sclerosis, and she suffered for about 8 years, 3 years at home, 5 years in a nursing home. While we were going through the process, we were being sued by Albany County, who were attempting to recover the expenses of our long-term care. Of course, we tried for many years, I used to work in the aging field, to get her long-term care health insurance, and we were told that because she had a pre-existing condition for 30 years, she would be ineligible for long-term care. So the day eventually came when she became symptomatic that we had to go into our funds and eventually go on Medicaid and eventually get sued attempted to be sued by Albany County. Now, I happen to be an Irish citizen, and she got Irish citizenship through me. I was able to bring her to Ireland, would have been able to bring her to Ireland, where she would have gotten long-term care health insurance. She's an Italian from Schenectady, New York, go figure, and she would have been eligible from day one she got off the plane. Now that didn't talk about injustice. It simply did not seem right to me that I'm being sued by my own government here, while the day she walks off the plane in Ireland, she would have been eligible for long-term care health insurance over there. So under the single payer, with this kind of situation where the county or the government go after you when you reach a point where your long-term care needs are such that the government would attempt to reacquire the amount that they spend on your long-term care system. That's my question. Thank you.
Well, I'm not going to gloss over that by saying that it would be an easy solution. That's a serious policy question as to how we would deal with long-term care of disabled people, long-term care in general. Exactly how right now there's this peculiar mix of Medicare, Medicaid for the long-term care and personal responsibility. And that, by the way, in the New York Health Act, the single payer that's been proposed for New York State, has not been addressed. Your question has not been addressed. It's written in the plan to do that within the first 2 years of the program, but and it's a very thorny problem. I hear why this is so irritating, and it's just plain it makes you very angry. It has to. It makes me angry to imagine how you guys have been feeling. This is, there's not going to be an easy solution. It's something we ought to sit down and say, what's the best we can do on this? And there are a lot of considerations. So I feel like I sidestepped your question, but I don't have a simple answer.
So I think that the best example of a specific reform that would work is the bill that former Congressman Conyers co-sponsored led for many years, H.R. 676. It's still before this Congress. It actually has more co-sponsors than it's ever had, well over 100, but not a majority, obviously. And long-term care is completely included. So the long-term care, all necessary long-term care would be funded by the single payer. So there would be no co-pays or deductibles or anything on the patient or the family of the patient. I have to editorialize and say that when I learned about the so-called Medicaid spend down, which was, I think, in my internship, it was one of the most shocking things that I had learned about. And I recently came across a story because I met this family from Watkins Glen. In Watkins Glen, they were rural Watkins Glen. The patriarch was a rural postmaster. The matriarch raised 8 or 9 children. They had a farm. When they got into their 80s and were doing well, they hired an attorney to put the farm in a trust that would be in their son's name because they anticipated that if they were ill and needed a nursing home, and sure enough, in their 90s, they both got ill at the same time and needed a nursing home. but it had been a decade since the attorney had done the work, and they learned from the county that the attorney had died without filing.
Did you say what the spend down is?
So the Medicaid spend down is to forfeit your possessions and your wealth until you're eligible for Medicaid, which means until you're completely impoverished, so that Medicaid can pay the nursing home costs. And so there'll be the idea is that patients will be put on a schedule. I learned of cases where people, in the rural upstate New York, the family farm might have 2 or 3 generations living on it, but it depends whose name is on the deed, by whose asset. And there are legal protections that will protect a spouse if the spouse lives in the house, but nevertheless, it may end up being, may not be forfeiting all of your possessions. It may be some payment per month, but it's a very onerous thing. And the thing that I find culturally shocking about that is that we're talking about what is referred to as the greatest generation, right? These are the people who built the model of American independence, gave everything they had to build their families and their livelihoods, have long since retired from incredibly productive careers and now need skilled nurses because of a devastating stroke, because of a chronic illness that's now really become terrible. And they have no choice and no power. And the nursing home system in the United States, I can even go a little bit further, there's no EMTALA, there's no regulation. And when I say that EMTALA is the Emergency Medical Treatment and Something Act, that's when there was patient dumping. That's when the rich hospitals would send the sick patients who couldn't pay to the poor hospitals, and that's when the hospitals that were very pecuniary would turn patients away at the door. So EMTALA means that if you present to an emergency room, you must be treated. If you're pregnant, you must be treated. If you are transferring a patient from one hospital to another, there must be a real reason, for a care-based reason. And that act came about for hospitals. But when it comes to nursing homes, I'm trying to discharge a patient to a nursing home, and I have an opinion. I think that the medical director at the Heritage House in Troy will do a good job for my patient. That's my opinion. It means nothing, because I have no say-so. All that nursing home needs to say is that we can't meet the needs of your patient. They don't need to explain it. They don't need to take the patient. There's no way to get them to do so. And I believe that what happens is a very sophisticated wallet biopsy that I don't quite understand. And then the patients who pass that test get their pick of nursing homes, and the patients that fail that test go to the for-profit places. And the for-profit places these days in New York State, which has an otherwise not-for-profit health system, but except for some of the nursing homes, and of course a few medical facilities, but the nursing homes that are for-profit are owned by Warburg Pincus, GE Capital, Bain Capital, the Carlyle Group, private equity firms own a majority of American nursing homes at this point. And then the way that a finance capital company owns a nursing home is to subcontract the kitchen, to subcontract the janitorial service to another company, to subcontract the nursing staff to a third company, the electronic medical record is a fourth company. Any service that you can subcontract gets subcontracted, and then everything's a limited liability corporation. And then when the disaster happens, there's no one to sue. So even the threat of malpractice doesn't exist. And then it turns out, of course, that there's data that show things like high staff turnover leads to a poor quality nursing home. So what happens if you're paying the least to the aides in a nursing home? Well, they're going to come through, learn how to be an aide in the nursing home, move on to a nursing home that pays better. And so there are all kinds of quality measures that show that for-profit nursing homes, as I said before, are more deadly and also more expensive. They're not more efficient. They're less efficient because when you try to take the profit out of the care, then it ends up driving the costs higher. And if you try to take the profit out of every piece of the care, like the kitchen and the janitorial team and nurses, you try to take a little profit out of every piece, then you really drive the costs higher. So it just makes no sense. Profit-seeking makes no sense. And the fact that it would happen in nursing homes, the most vulnerable human beings, people who literally can't defend themselves, people who literally need help with food and changing and cleaning, that those people's dignity would be exploited like that is just appalling.
Thank you. Is this on? Oh, thank you. I think probably most everybody here agrees that universal health care is necessary. I have a couple just kind of really simple, basic questions about single payer. Like, why would it be so much less expensive? Like, as this chart shows, like less than a quarter of what the town is currently paying. So that's one. Why does it save a lot of money? And the other one is, what are the arguments you use about the government not controlling our health care?
Okay, so single payer saves money through several different means. Probably the single largest one is the reduction in administrative costs. Administrative costs include billing, include denials, include the salaries of all the insurance company employees, and we know that administrative costs for a large governmental system can be quite low. Medicare runs, traditional Medicare has costs, including the billing costs, of only about 1.5% of the money that comes in. In Canada, they're running with administrative costs in those provincial single-payer systems at 4% or so. I got that number, I think, about right. So in the United States, we're paying about 30% of every healthcare dollar toward administrative costs. Okay. Now so that chunk of it would be the single largest cost. In the United States, our VA department, our VA system negotiates the prices of drugs with the drug companies. They pay 60% of what you pay for at the pharmacy. And we expect a single payer and the law, the New York Health Act or the HR 676 would give the agency, the governmental agency, the right to negotiate with drug companies to lower that. Now, it used to be only $100 billion that nationally we could save that way. It's probably $150 billion by now. In any case, the the cost and of drugs and of medical devices, like prosthetic hips, for example, would be tremendously reduced in the single-payer system. We could argue about the question of whether fraud would be easier to detect in a single-payer system. But I think the simpler it is, the simpler the system is, the easier it's going to be to detect. There's always somebody who's going to try to game the system, and that has to be. But I do know that in the Eric Schneiderman's office, the New York Attorney General runs the anti-fraud Medicaid unit, and in New York State, they were part of nationally. The attorneys general found over a 5-year period that when they invested over that 5 years $1 billion into fraud detection, they pulled $10 more billion out of the system. I mean, the thing is that the fraud thing can really be dealt with. And it is worth working on. Are there any other?
Well, planning saves money because, you mentioned global budgeting of hospitals, so you don't have, our local example, we have 2 competing hospitals with these spectacular parking garages and pianos that play themselves. And whether or not those things add to the quality of care locally, I think is debatable. And so if we had planning and global budgeting, then there would be every reason to have cost control. And so if you look at the Canadian system and the American system, tracking about even coming into the reform in Canada in the early 1970s. And then Canada definitively bent the cost curve for the better, so Canada now spends half of what the United States spends per person because of its single payer. So there's the big savings that George mentioned of the overhead costs. There would be, I believe, savings in driving profiteering out of the system, but then the planning really yields the long-term cost control. And the other thing about healthcare, in my opinion, is as I've been talking, I mean, it should really be the proper subject of a democracy. What are the health goals of our nation? We could talk about the foreign policy with respect to China or the monetary policy with respect to interest rates. What are the health goals of the United States of America? Isn't that a proper public discussion in any democracy? And if we had health goals that were extremely extravagant, maybe the public would like to pay for them, right? If we wanted to lead the world in the latest science, for example, or nutrition, you know?
It turns out that some of those goal interventions are pretty simple. Canada has 3/4 of their docs are primary care, and only 1/4, a third or a quarter are specialists. It's the reverse in this country. If you look at any system that is really good at keeping the prices down, there's a predominance of primary care. You know, as a country, we can look at this kind of issue and say, do we need this many specialists? Would it really make sense to provide more primary care to take care of most of our problems? It could be a national goal. Excuse me.
No, I think that's great. And then the second part of your question, I think that obviously I do not believe that government bureaucrats should be in between the doctor and the patient or the nurse and the patient when it comes to making decisions about what to do next, right? The government should provide a policy that provides the support for that relationship and then protect its privacy. I can't imagine a private interest protecting that privacy. And in fact, my experience is the opposite, that the job of the insurance company is to get between the patient and I. At one point, the most egregious, in one hospital where I worked, there was a woman that was hired by the insurance company, very smart reviewer, very good, who would literally be on the unit fighting me for the chart to see what I wrote, to see whether or not the insurance company was going to pay for another day in the hospital. And I thought that this person was interrupting care. I tried to take it to the ethics committee of the hospital and say, I think it's unethical. I didn't invite her, and the patient didn't invite her, and it's not about her. She's a nice person. It's about the question of whether it's ethical. And they said, of course it's ethical. We have a contract. You know, and so the private interests, if the private interests are trying to manipulate the patient-doctor relationship, bad things happen. And there's more sort of bad news on this front. So the pay-for-performance efforts where you pay incentives to doctors for quote-unquote quality have been shown to fail. The quality goes down. The altruism goes out of the profession. The costs go up. The incentives are perverse, so that if a patient is very sick, the doctor will be penalized. So either the doctors who want to care for the sickest patients will accept the penalty, or the doctors who want to cherry pick will find a way to avoid taking care of the sickest patients. And it just leads to a mess. And it hasn't saved any money, because the idea of this cost sharing, it hasn't. So when profit incentives are experimented with, I think they're pretty convincingly to be shown to be failures in the most modern experiments on this line. And so the best system would probably be one that was publicly funded toward needs, not incentives, toward money. Stick with what the patient needs, and I think that those lead to better efficiencies. Okay, where should we go?
Thank you.
And thank you.
There's a hand here.
I just want to add one other thing before we go on.
Yeah.
I'm going to add something about the cost. On those papers that I passed out, I showed that the local governments, the county, the town government, schools could save a tremendous amount of money. One of the reasons that your local government would really benefit from this is that these calculations are based on a model that's of relative, and this is specified in the New York Health Act law, that passed the Assembly, that it has to be a progressive assessment of income, of payroll income and of unearned income. Progressive assessment. Now that means that if you earn very little, you pay a lower rate. If you earn more, you pay a higher rate. Public employees tend to be at the lower end of income. So, for example, a county worker with a $50,000 a year income, that's a guy who works in the garage, is only paid a rate of about 4.5%. He's assessed at 4.5%, which is about $2,200. And he's only, as an employee, he's only responsible for 20% of that. So he's going to get his health care for $450 a year, this guy for a $50,000 income, with no copays, no deductibles beyond that. And it's going to include the dental and eyeglasses. Now, what this means is this transforms this guy's life, because they don't have to panic that the kid has a cold. The 3 kids have colds, and they all have to go to see the family doctor, and they're all going to have copay. I mean, this is a huge cost reduction for this average kind of worker. Most public employees have below that, the median income is below 50,000, is 50,000 or below, somewhere right in there. So it means that the rate that our government, local governments have to pay will be way lower than what they're paying now. Anybody know what a family, a CPHP family policy is? Yeah, it's between $22,000 and $26,000. You hear that? It's approximately $25,000 for one of those hides, and you still got a $1,500 deductible.
Should I go? Where should I go? This man?
My question is.
The mic, please.
I'm sorry. My question is a little more mundane than a lot of these. I'm a union guy who has very good health insurance. I'm very lucky. I've found a way to cover my family. Most of my friends are in my same position. They're my coworkers. How do I, at this point, I've come to believe, as you guys do, that we need a single payer program. I've dealt with my family and my friends who are in this group, who have convinced me that this is where we need to go in the future. But how do I convince my friends who have good health insurance and are not being crucified monetarily for that? How do I stand up to them and say, what we've got is not the right way, we need to go in a different direction? How do I convince my union that we need to not cover ourselves and...
Okay, well, if the argument about what's right won't get you anywhere, and then there are a couple of things. Do they pay taxes to Albany County?
Of course.
Would they like to get rid of Albany County? I'm not sure I brought that thing, but the tax, it accounts for, well, I don't think it's on there, but it accounts for about 45%. That's the average in the state, 48%. 48% across New York State of your county property taxes are Medicaid costs that the counties are healthcare related. Okay, so when county the Medicaid cost for New York State for Albany County is on there. It's about $60 million. a year. So if you would like to see your property tax go down by half, then we ought to go this direction, okay? Another thing you might mention to them, wouldn't you be happy, would you and your friends be happy if you have an insurance plan that's better than, equal to or better than the best New York State insurance policies that are available right now, the ones for New York State employees? You'd probably be sad, they're just like the ones you have, except you wouldn't have any co-pays or deductibles. Think you could live with that?
I like that argument. So you might not know this about me, but I'm executive board emeritus, a member of the Public Employees Federation. And so and when I was young, I actually worked in a couple of organized union places. So I know the trade union movement well, and I've worked closely with the All Unions Committee for Singlepayer. And I've spoken at the Steelworkers Executive Board a couple times, like their International Executive Board.
And speak up, Andy.
So the question of unions is dear to my heart. Just thinking broadly, everybody knows the Triangle Shirtwaist Factory fire just over 100 years ago, right? Well, when that happened, appalling working conditions, the women that died were known to the city because they had waged a valiant and violent effort to unionize before the fire. So the young girls had been clubbed down by the New York City police on the picket lines again and again, and it was on the papers over and over again. And when the fire happened, the public consciousness was that it was those girls, those very same girls that had been trying to form a union. And I think that consciousness explains why that was the biggest mass event in New York City that had ever happened, the Triangle Factory funeral, when there were hundreds of thousands of people in the streets to honor those who were killed by unsafe conditions. And what followed, you could almost draw a line, was a tidal wave of progressive reform on behalf of all working people, basic safety and health, basic wages, ending child labor. You could almost draw a line from that movement to the New Deal. And it was because the unionists had the consciousness that it's for all working people, not just us. And old Samuel Gompers, the head of the AFL-CIO at that early part of the century, was against the idea of national health insurance because the Gompers idea was that we'll have better health insurance for our workers, and then the poor slobs will want to join the unions to get the health insurance. That was Gompers' idea. And so Gompers was against national health insurance. But the CIO leaders coming out of the war were with Harry Truman for national health insurance. And the AFL-CIO absolutely won Medicare, in my opinion, in its behind-the-scenes maneuvering. The pressure of the union movement won Medicare for this country. And there's a proud role played by a local doctor, Dr. Van Essestein, who was a Columbia County doctor who was actually given a telephone by the AFL-CIO to do his work to try to win Medicare. So I think that the question of the unions, and the AFL-CIO has recently affirmed at national conventions that social insurance model is the way to go and that we should have some sort of single payer. And we've tried very, very hard within the leadership of the AFL-CIO to talk about how important this is. I think for union members, I think the union movement that wins its place in the American working class fights for all workers. And if you think about this reform from that point of view, a lot of single-payer activists like to talk about the benefit to businessmen, that they now pay this huge portion of the payroll to the insurers, and small businessmen who would love to see their workers covered because they're caring people. But think about what it would mean from the point of view of, say, organizing Walmart. If you didn't have to worry about whether or not your kids were sick, if you didn't have to worry about if you organized a strike, you would lose your insurance the minute you went on strike. You know? And I know we recently had a pretty militant strike in Waterford, where the workers went on out against Momentum a winter ago and stayed out. And healthcare, I got to know many of the strikers, the immediate personal healthcare problems that happen. You know, you go on strike, you lose your insurance. The union says that they'll cover everything, but in the meantime, it looks to the computers like there's a lapse in insurance, and then there, you know, it's just a mess, you know. And if your kid has leukemia and you show up at the clinic and they say, oh look, you don't have any insurance, we have to verify that, come back tomorrow. Wait a minute, I don't want to come back tomorrow, my kid has leukemia, you know. So these are real life problems. So I think from the point of view of organizing a union and from the point of view of building a union movement, I believe that the trade unions have the most to gain in advocating for this reform. And I think that it is absolutely in the interest of working people, because it's not just a rights demand. We're not talking about, yes, women won the right to vote in valiant struggle. And it was the same kind of, it was like the Frederick Douglass struggle he's talking about, you know? In the end game of women's suffrage, Lucy Burns and Alice Paul and their comrades are tortured at Occoquan, right? They were force-fed. They were tortured in American prison, political prisoners in the United States, because they protested for the vote in the face of the war. They were called traitors. But they also knew it would put them on the front page of the paper every day, right? And they knew it would push their struggle over. So they had that kind of militancy. They won the right to vote. That's a right. That's a formal democratic right. The right to health care is an economic right. It crosses a new line. And to see the trade union movement win an economic right for all people, that we have the right to dignified care, I think that that is an absolute achievable next step. And then saying all that might sound very radical. It doesn't threaten anything at all about capitalism. Every other capitalist country has some version of this, right? People go on and they do their millions, they do their trades on Wall Street, but everyone has health care. And this is why I've begun to believe that, as shocking as it sounds, I'm getting more and more optimistic. Because the people in charge of this country have chosen the most ridiculous political crisis, and I don't really understand why, maybe. I mean, I do know that they're not making the profit they think they should. And they need somebody to try to squeeze some more out. And they're willing to have any kind of chicanery to get to that end. But there's a political crisis there. And as that crisis deepens, if we have an epidemic crisis, an environmental crisis, a war crisis, a deeper crisis, besides just the political silly crisis, a deep crisis starts to set in, something will have to give. And this demand has been around for 100 years. This demand has been around with all of its evidence. This demand has people who understand every aspect of it, and it's worked in all these other countries. And so when you're in a crisis and you reach on the shelf for something that's going to get you out of it in an emergency, meaning a concession to the working class, you're going to reach for something that's proven. And this is proven. And so I'm extremely optimistic about our prospects from the point of view of the class struggle. Thanks for the question.
One of the things that we're all aware of in this past few years is this widening gap between the wealthy in this country and the rest of the country. And this tax law that was passed, did everything just to make it worse. Our middle class has been confronted with, when you look at the rise in wages that have occurred, it's just stagnated through the middle class. One of the reasons it's stagnated is because the rise of the cost of medical care has been going up at double the rate of inflation for a long time now. And which is eating up what might have been legitimate, reasonable, modest increases in salaries for working people. That's another thing that you and your buddies ought to review.
I just wanted you to address also the fact that, yes, he has the best healthcare insurance, but still our outcomes are not what the rest of the world has. So the best insurance in the United States is still giving us terrible outcomes.
Well, and also, unions should be bargaining for wages and working conditions. And, there's all kinds of insurance that's not health insurance. Maybe there's insurance to go back to school, or insurance to take maternity leave, paternity leave. Maybe unions could bargain creatively for all those things. And I think that when it comes to the Taft-Hartley plans, I think that's my personal best idea. That, okay, you have a Taft-Hartley plan for your union. Do you know, guys, is that shorthand? There was a major attack on the unions in the 1950s. There was a bill called Taft-Hartley. If you're a multi-employer union, like if you're a carpenter and you go to different, you might go to say, 7 different job sites in the course of a year, getting paid by 7 different bosses, but all through the union. Many of those Taft-Hartley funds, the workers are now paying $13 per hour into the health fund for their health insurance. And so the Taft-Hartley funds are struggling, but the unions this is an economic pool of money that the union controls. So you can imagine there are people that don't want to give that up, right? So my answer to that has long been that you can still have a fund. You can still have a fund, but it doesn't have to go to health insurance. Let's be creative. Let's put it to something else. And bargain for it and fight the employer for it. And say, you got to pay into our cosmetic surgery fund, whatever you want. So, all right, next, somebody help me, please. I did see
You know, you haven't picked anybody on this side.
Oh, okay, that helps.
Would you mind talking a little bit about terminology?
I'm sorry.
It sounds to me like the 3 terms, national health insurance, Medicare for all, and single payer, are not identical, very similar. Are there some advantages to using one of those terms rather than another? I mean, the movement is tended to switch over to using Medicare for all because Medicare is one of the most popular public programs that's ever occurred in this country, and so that using that as a starting point has made sense to a lot of people who want to spread this idea. But it's Medicare improved Medicare. Because what's wrong with Medicare? Well, even traditional Medicare, there's still 20% that's not paid for. The Medicare Part D put the drug program put huge money into the pockets of the pharmaceutical industry, and it just made life very complicated for people. There's a whole lot of things in Medicare that could be improved. And it doesn't cover dental work, for example. It could cover everything. And that's what HR 676 is called now, improved Medicare.
I had a question, I guess it's about the logistics of how this works. But when I get a bill, and I have a Medicare Advantage plan, when I get a bill, there's a huge amount of money, say, for a procedure, and Medicare pays maybe 30% of it.
Or 10%.
The doctor has a large bill, and he only gets paid a little bit of it. Well, if everybody's on a single-payer plan, who's paying this extra money that the hospital says they need? Who's paying for the building that the hospital has? The people who clean the floors, who change the beds? Who's going to pay that bill, and who pays those bills in other countries where they have a single payer plan? And also, I'm curious, how do young doctors respond to your idea when you speak to them and they have some gigantic bill to pay off from their medical education? Are they for it or not?
In general, young doctors think we old folks are completely crazy to do it the way we do. It's pretty easy to get enthusiasm from young doctors about this. It just seems pretty sensible.
Well, I think it's pretty convincing that a majority of physicians want some form of national health insurance. I think the data is there to say that boldly. So in England and Scotland, and maybe Scotland these days is a better example because there's been a fair amount of privatization in England, there's a National Health Service. So the National Health Service owns the hospitals, owns the clinic, Ireland, the National Health Service of the UK, they own the infrastructure, and the workers, the doctors, nurses, janitors, support staff, what have you, get a paycheck from the government. They're public servants. It's a public health service. And that is a model that people call socialized medicine for some reason. I don't really know. I think that gets to ideological talking points of the right wing in the 1950s, but that's okay. It's referred to as socialized medicine. Then there are systems like in Germany where there are private, quote-unquote, private payers, and the private payers reimburse the hospitals, which are private entities, but the health regulation, the regulation of the prices is done by the government. So that what everybody gets to charge and what everybody gets to be paid is the public's business. And in fact, the institutions and the insurers open their books. So to call it private health insurance doesn't quite make sense from the American point of view, because the heavy, heavy, heavy regulation of those private entities really makes them subject to firm public laws. And then the idea in Canada or Taiwan, for example, is the idea that some of us think is this most practical small increment for the United States, which is there would be one public pool of money, private infrastructure, not-for-profit private infrastructure. You can't make it would abolish, actually the bill in the House would abolish for-profit health institutions. And then those institutions would be paid by the government, but they would be paid in a way where they had to bargain with the government. The fees in Canada, doctors' fees, the Royal College of Physicians and Surgeons for the province negotiates with the province, and then they go to contract negotiations, and they come up with what the doctors are going to get paid. It turns out that there was a time when they wanted in Canada to add mandatory bureaucracy, extra forms. Well, the doctors bargained, and we're not going to do those extra forms. It's kind of case by case. Hospitals, we think, I think the proposal that we would like to make would be paid on an annual budget. Okay, last year you spent $105 million, and next year, with population growth in your city, you're proposing that you'll need $108 million, $110 million. That's your budget for the year. Go have it.
So that's
So
the
there'd be none
global
of
budget.
none of these bills, right? And when it comes to patients, we would all pay what we could on some tax basis, and no taxes are fair, ultimately. But it turns out no matter how you study this, whether it's a payroll tax plus an income tax, or some kind of small contribution, the amount of money that it takes to fund the whole system with a tax comes out to be less than we're paying now out of pocket, plus almost everyone's a winner, because when everybody's in and nobody's out, then everyone shares the responsibility, and it's that payment that then, there's no bills after that. It's that payment that gets you access to the system. And I would say that the ideological problem that we have is that that's characterized as some kind of altruism, where you're paying for the illness of another person who you don't owe anything to that person because they're ill. And it's not really that altruism. It's really the social solidarity model, the idea that, the very basic idea that it's there, but for the grace of God go I. That's what he said was the very first thing. He said fairness, it's fair. I might someday, I will someday, we're all going to die. Most of us are going to get ill in that time before death. We're all going to need care. We all need the assistance with trying to become as healthy as we can. It's the idea that I will need this, and so if I pay into it, it'll be there when I need it. And I have debated and had a great ball with my libertarian friends, and even a very famous member of, what's that great libertarian group? Nothing. It doesn't matter. We had debate at Albany Medical College, and they were nervous. We were going to fight so hard that we would come to blows. They were scared. But I kept on the point that if you have the individual responsibility for the best quality care for your family, I'm not talking about somebody else's family, You're a libertarian, I get that. Just the person, not you, I'm talking to him. Your personal responsibility, well, wouldn't you want to use the evidence to have a system that was as best as possible at the lowest possible price to you and your family as a sense of personal responsibility? And the evidence would show that if we all share the cost and we have some planning, then the system is there for us when we need it. And wouldn't that then be the most individually responsible? And this doctor, he was a doctor, lawyer, he was a famous guy. He threw up his hands, he said, you know what, I'm also a Federalist. If you want to try this in New York, go for it.
I was going to ask, oh shoot, I just lost. Does any of us want to abolish the insurance that we require if we're going to drive our car? Do you want to be driving on the street when anybody else doesn't have insurance, or does it become would we all consider it reasonable to insist that we all have car insurance? Duh. Yeah. No, so this is an example, is that having insurance guarantees that when bad things happen, there's going to be some way to manage it. And health insurance is so easily like that.
Except when you choose not to drive, you have to pay for the car. It's not.
Yeah, and so but you can't choose not to get older.
That's true.
And you can't choose. You don't get to choose whether you have cancer or not.
That's true. But to say that health insurance could be parallel with states.
So the analogy is not perfect.
In New York State, if you drive, you have to have insurance, but you can choose not to drive, and a lot of people do. In New York State, we're all going to get sick. So there should be some way. First off, I don't disagree with you but your parallelism.
Yeah, no, there aren't any analogies that are 100% intact. You're absolutely right.
For one thing, we all do pay, part of our car insurance covers uninsured drivers. Just to notice that. And also to notice that I can't imagine that everything we would ever want in healthcare would be covered. And a case in point from the Canadian system, a friend of mine had a son who had phenylketonuria and had the kind that Kuvan was very, very responsive to, which would mean he could pretty much eat what he wanted to, but he couldn't get it in Canada. So they had to come to the Cleveland Clinic to get that very fairly well regarded and respected treatment. They had to come to the United States to get it because Canada wouldn't cover it. So just some comments. I think there's got to be some lines drawn somewhere.
Well, those lines are going to be drawn all over the place. Is that, Andy described the people limping in the neighborhood, in the poor neighborhood. That's how we ration medicine in this country.
But even with a total care, you're going to have to ration.
Of course, we're going to have to say, at this point we can cover this, at this point we can't. And those decisions ought to be made by people who are using the system, who are knowledgeable, and try to pick treatments that are the most, can be scientifically shown to be helpful and so forth. And it's going to be an ongoing adjustment. It's not a constantly moving target that we're going to have to do the best we can on. We ought to be working together on that kind of thing.
I totally agree, but just the record.
Hi. First, I want to thank you for coming tonight. I'm a healthcare advocate. I have a disabled daughter. I know all too well how screwed up our healthcare system is. To the unionist who left the room, unfortunately, I would note that the many Teamsters pension funds have been cut this year. And so when you're relying on a union or any other private entity, there's always the economics of it. And it's not guaranteed. To the lady who asked the question about costs, I worked for the state Department of Social Services. I had some involvement with Medicaid. Trying to figure out what to pay a hospital is one of the most complex problems facing bureaucrats. You know, in 2001, my mother spent one day in the hospital, and the bill just for that one night, she died that one night, was $1,000. She could have done much better at a fancy hotel in Manhattan. It's really complex. But hospitals are very different than doctors. They have an entirely different methodology. So don't think the hospital is getting only a small fraction of what it bills for. But there was an article this week, not an article, a letter to the editor in the New York Times, in the Times Union, and it was critical of the single-payer system. And you know, I could see right through some of the comments, but I think for purposes of the audience, it would be well suited for you to address. This was written by the Business Council, I think, or one of the business files. If you read the article, and you know what I'm talking about. If you didn't, I remember 2 points from the article. High taxes and tens of thousands of people will lose their jobs. And that's why they were opposed to single pay. So if you could, for purposes of the audience, expound on.
Well, let me tell you, I just sent my letter to the Times Union before I came up here. And you know what? Let's take the loss of jobs first. A bunch of insurance employees are going to lose their jobs. But you know what? A bunch of insurance employees are nurses. There's going to be room for them in this healthcare system. A bunch of them are statisticians. This healthcare system is going to need statisticians as well. So some of the talent and technology, she was worried about both the loss of talent and technology, are going to be incorporated into the new system. A great deal of it is. She did not address the question of what kind of effect this would have on entrepreneurship in New York State. If somebody is contemplating starting their own business, number one, she feels she can't leave her present employer because she'll lose the health insurance. So taking the chance of going out on her own may be blown into the air. She knows that she'd like to be able to hire 3 people to work in her small business, but she doesn't feel it's really moral not to offer the health insurance. With this kind of system built in, everybody is resident included. She knows that her employees are going to have the health insurance. So that's the, I was trying to find things that I could agree with this woman, and from the Business Council. But you got to say that we don't know for sure exactly how jobs are going to sort out. That's a crystal ball that I cannot see into completely. But I think it's much more. It's not as bleak and simple as what she seemed to imply that it was. Here's the other thing that you mentioned was the huge taxes. Well, look, she said there was going to be $200 billion of excess taxes, and just to most of the money that comes into the New York Health Act that would come into the North Act would actually be federal dollars that are already coming into New York State. If the act goes forward in the way it's proposed, they're Medicare dollars and Medicaid dollars, close to $150 billion or something like that. The taxes, if you want to call them that, or assessments, as the Act likes to call them, are actually on both earned income and unearned income. Payroll tax on earned income, and unearned income would be on dividends, interest, right? Things like that. It will be responsible for just under $100 billion to bring that in. If you look at remember what I said was if you're willing to use the financial analysis that I used here, somebody who's earning $50,000 a year is only going to be paying out of his wages per year $450 and have full health care. The thing is that who's going to, remember 98% of New Yorkers would pay less than they do now for their health care. 2% of New Yorkers, a very powerful 2% of New Yorkers, is going to pay more. And they're not going to come along without kicking the can. And this is a serious problem. As to how the political will of the rest of us is going to build strong enough to move this forward.
And George has done this great imagination project of how this would impact local taxes because of the shift. There'd be more taxes in place of premiums and out-of-pocket costs. There would be more taxes, but then there would be fewer taxes because at the local level, there would be a shift. Things would be inverted, and that's very creative.
I just want to make sure that stay away from that. Make sure that you realize that all the healthcare premiums we pay now go away. These taxes are in lieu in place of the healthcare premiums. So you don't pay both.
But there's another case to be made, which is that if you think about upstate New York, which I know quite well from the medical point of view, most of our upstate counties are really shockingly underserved. And many of the upstate cities have unbelievable inner city poverty, in Troy and Syracuse, Buffalo, Utica. If every patient were suddenly a quote-unquote paying customer, in other words, if anytime that there was a provision of medical care that was deemed necessary by the system, the clinic would get paid. Now would be a time when Greene County could have a hospital, when Washington County could again have a hospital, and there would be a chance to build clinics. And it was a few years ago, the California nurses made a stab at an economic study on this, and they came up with some bold claims about what an economic boost this would be, because there would be the chance to build infrastructure, and when you build a new health facility, there's all kinds of jobs. You could think about it in old-fashioned Keynesian terms as a Keynesian multiplier. That study used an econometric analysis. I don't think we've done or have a study like that, something that I've often thought we should do. Like if in our own counties, and I think the Business Council would be eminently qualified for something like that. So just in terms of the imagination, we're really talking about a social change that's very meaningful for our communities, and we could be more creative. So I'm looking at the clock, it's 8:32. What time are we?
We're till 9.
We have 28 minutes, so there are a couple of people over here.
There was one other thing that the Business Council president brought up that I wanted you to just think about, was that she said it would completely eliminate choice in health care. And I said, my wife looked at this and she said, wait a minute. You know what? It eliminates choice in insurance company. There would only be one insurance company, that would be the public payer. The whole idea of the single payer is you go to whichever doctor you want to. It gives you, for the first time, there would be complete choice in healthcare. And so so she makes a statement in this article, in this letter. And it's really sad, because somebody's going to believe that and is not going to be thinking what she's really talking about.
So I've been a proponent of single payer national coverage in part because I wouldn't be alive if I had not been under a single payer system whenever I was born. I'm a physician. So the question that we posed initially is what is standing in the way in this country? And I think you sort of mentioned it. I think the problem is that we have a large part of the population, when they hear the word socialism, immediately backs away and says, that's un-American. And the question is, how do we get the message that the communists are gone, the Red Scare is over? How do we convince those people, the people in this audience are probably already convinced? How do we get to the rest of the country, the one who voted the Schlemiel in office, to his place, or didn't vote for him? So that's the way I think Andrew said, well, we need a national crisis. Right? That's what he said, in order for it to happen. Can we engineer one? We have one now. The question is, do they know? How do we get people to recognize the crisis that we're living in?
So this is a very, very difficult political question. Across the hall, there's a meeting of Democratic Party people who had a meeting that I went to say that single payer should never be a litmus test for the Democrats running in 2018, because if single payer becomes a litmus test for running as a Democrat, then it will become very unpopular, because whenever the Democrats touch healthcare, it's like a third rail, and then the party becomes very unpopular. So what we really have to do is go for corporate money and defend the insurance companies and say that what we've got is the best of all possible worlds and just lump it along. And so this is kind of the view from the top. Meanwhile, across the country, PhD doctors like us, who are getting gray, are being invited out to Democratic Socialist of America meetings in every single town with these 20-year-olds who want to hear about how single payer is going to actually be won. And so I think that what's happening is this incredible split politically. And I think that we really need to get serious about building a movement, a real mass movement, if we're going to think about winning this.
So how do we do that?
Well, we know the old-fashioned way. You have to recruit people one at a time at your kitchen table. You need to pay dues so that you have political independence. You need to have your own press. You need to have your own, a mass movement that really has that kind of compelling struggle. And I think that what happened with this issue, in my opinion, is that the single-issue movements came about in the 20th century because of McCarthyism. So anytime you were a multi-issue person that wasn't within the mainstream, you were red-baited. And so the way that some activists found a way around being red-baited was by going for one issue at a time. And this issue, has come and gone, but always been red-baited. So I think it's a really serious question, because if someone won't even talk to you on that level. On the other hand, the best things about the country are the volunteer fire company. The best things about the country are the church side, the social solidarity model of the country that we all care about. And so I think that discussion is ready to be had. And then there's another change in consciousness, in my opinion, just from doing the activism, because I put myself out there, saying pretty boldly that I really think we all have to do this. And I've been looking for the big pushback. I don't get the big pushback. I don't get it, even from the most conservative quarters. Everyone who needs health care deserves to get it. That's something that should happen in the country that I live in. That idea is already won. I think it's a lot like, 1917, 1916. Everyone thought that women should be voting. There wasn't a big controversy about that. It was that it hadn't yet happened. And so I think we're in a funny moment with respect to winning this demand. And I think that we absolutely have to have relentless pressure. If many of the mainstream liberal Democrats like Kirsten Gillibrand are coming over to this idea, well, that gives us an opening to build pressure, And then I think that there should be like a Diogenes project to start looking for Republicans for single payer. There are some great examples. The chairman of the board of the American College of Cardiology wrote a beautiful piece a few years ago. I'm a Republican and I'm for single payer. Because he said he couldn't stand the idea that some of his patients were left out. It was a beautiful piece. And so I think that ideological divide we should take on. And I also think at the grassroots we should take it on.
What about the effect of the lobbyists and the insurance companies in Washington?
Yeah, so we're up against a ridiculously powerful foe. I mean, preposterously powerful foe. And I absolutely get that. But I don't think that in my mind, the next thought that I have is, oh, then I have to compromise. That's not my next thought. My next thought is then I have to fight harder. I have to figure out what I'm really up against. I have to take the measure of what I'm really up against. And it's a very, very peculiar thing. If you've been in this debate like we have, and you follow like, so for a long time, David Himmelstein and Steffi Wohlhammer published articles that talked about how it was that there were so many tens of millions of people who were uninsured. And then they and their colleagues and some of their friends and some other people started publishing articles that said, if you're uninsured and you control for all other things, you are more likely to die. And it turns out that for every 1 million people uninsured in the country, about 1,000 preventable deaths occur per year, about. And that data came back and got very consistent. So what was a response in the mainstream discussion in Washington among the very lobbyists who are the foes? Well, everybody should have insurance. Everybody should have insurance. You know, insurance is good. Insurance is good. So that became the talking point. And this is where you get this term single payer. The question was, which of these terms? You know, because the idea that everybody has insurance equals universal health care, well, that doesn't really correspond. You know, like in Massachusetts, almost everybody, quote unquote, has insurance. Oh, except for immigrants. Oh, except for, and you know, and then you have Medicaid, and you have the whole crazy quilt of what it really means to, quote unquote, have insurance. So I think that the point I'm trying to make is that the temptation in modern politics is that you go to the bargaining table and you look for what you can accomplish. You negotiate against yourself as the first step. Where do we get that idea? You know? I mean, yeah, they're powerful lobbyists. They have hundreds of billions of dollars. The system has worked very well at making some people very rich. That's the system that needs to change. So, I mean, let's take our own pulse, get together, and figure out our next steps. You know. And I can think of tactics we might try. Like I would love it if Congressman Tonko, he's been a single-payer stalwart year in and year out. When Newt Gingrich was in the minority, what Newt Gingrich did were special orders. He would take that time on C-SPAN to give a speech for half an hour to the whole country about his ideas. The single-payer people in Congress could use C-SPAN that same way. And one time I said to a congressman, what do you think of that idea? He goes, this is how it's going to work. You write me a letter as a doctor about your patients. I read the letter on the floor of Congress, and then I give my spiel. I'm like, let's do it. He's like, well, check me in a few months. You know, in other words, let's get these guys to move. There's real targets. There's real action to be had. You know, we can. So it's a question of building a movement, thinking of the tactics, thinking of the strategy, but with confidence, because this idea is so much in the mainstream. It is so much in the mainstream, and so we should really be confident. So, is that useful?
Can I just ask a question about the Amazon, Morgan Stanley, and other sort of corporations that are looking for value that they're going to do for their own employees and the cost of caring for their employees?
I do not know what it is.
But is that another avenue to sort of get at, I mean, I'm guessing it's some kind of self-funded design of it.
Yeah, it's self-insured.
Yeah,
But they're looking for value, they're going to have to deal with something broadly national, is that
So I think that in my
a
opinion,
model?
it's not a model, but it's an opening. So that if we're building a movement, then we go to their leadership and we say, hey, you want healthcare that means something, do it for the whole country. Get on board. You know, I think that's sort of the attitude. Sorry.
I think the question is, when is the right time? Providing people do believe that a single-payer system is the correct way to go, it's the best way to go. When is the right time? I was able to be I was able to be in a smallish group with Congressman Tonko last week, and the question was posed very squarely to him: do you support the Connors bill? And the answer was, not at this time.
He's a co-sponsor.
He's a sponsor, and yet he's concerned about your timing. He's concerned that we're going to see Medicaid and Medicare under attack. when Republicans decide that they have to balance the budget somehow, after all the tax cuts. And also, his approach would be to shore up the ACA. So you have even people who are theoretically on board with the single-payer system saying this isn't the right time, that it's politically risky, that we could lose, that we could never gain Congress back if we go with something that bold. And I don't agree with it, but that I think is right.
So the congressman needs help with fighting for reforms that will actually work. Right? Because these ideas like expanding Medicaid and inviting more profits into the system are not working. The Affordable Care Act is not working. It's pushing costs onto the poor. Yes, some 16 million people got Medicaid, but Medicaid is kind of an indefensible program, right? So we really want to talk about reform, we really want to talk about the next steps, then we have to look for workable solutions. And so this becomes a very silly discussion. It just becomes an excuse to retreat. And it is true that many of the Democratic Party, I've often said that I think the Democratic Party is the fiercest opponent. Remember Hillary Clinton in the campaign? Single payer, never going to happen, quote unquote. Right? So in some ways, the fiercest opponent by sponsoring the bill but planning to never vote for it, if you can imagine. In New York, Assemblyman Godfrey always introduced his bill with more co-sponsors than it would take to pass the Assembly, but it never got out of his own committee. It didn't get to the floor. It didn't get voted on. It took the activists to pressure the Assembly Democrats to vote on the bill that had more co-sponsors than it would take to pass the Assembly. And then they started working on the Senate, So I think those are focal points of the struggle, not really, it's not time.
The struggle has to go on constantly. I've been doing this for more than 15 years. I sort of lost track of how long. But I've settled into realizing that we have to make sure that single-payer noise is going on constantly. We have to use the language. We have to make sure that people have the vocabulary to talk about it, understand how it would work. I guess my feeling about the New York Health Act, I would prefer a national program, but the beauty of the New York Health Act is it allows me to bring this up and say, how would it affect us locally? So it's been very useful in that regard. We each need to independently, each of us take the responsibility of talking to people about it, getting it up in conversation, keeping it going.
I think that as far as getting your Democrats or your congressmen to go to work is to point out to them that the reason we're in this mess nationwide right now is because they were not working before. And if they're just sitting here waiting for the right time, they might not be sitting in that chair at the next election. I think a great model for getting things done are the states with the marijuana. People went out, they just did it themselves. So we're going to defy, if we can't get a national law, we're going to make it a local law. And I think that we're seeing this go across the country.
Related to what we're talking about right now, I'm sure many of you realize that in Canada, the province of Saskatchewan really started their current system. And they were the incubator or laboratory for many, many years before national health insurance was adopted by the rest of the country. So my question to you gentlemen is, obviously you've been studying this for a long time. Is New York State the laboratory, the incubator, or are there other states that are more likely? Would that be more realistic to think that individual states would start this rather than it all of a sudden go nationwide?
The Canadian experience certainly tells us that, of course, that would be a possibility. There are regulatory hurdles that would have to be negotiated, but we should have the states' rights people on our side in that argument, in that discussion. New York State, with its 20 million population, California, with even more, we're as big as a European country. Obviously we can do it. It would be, I see we need to push forward on as many fronts as we possibly can. And if I'm seeing I've been really heartened about this, having done this kind of activism for so long, is that so many people like yourselves are here. People are talking about it, asking really good questions. As that happens, it's going to spread, and actually New York State will have a chance to do it.
There's two words, unfortunately, in our political culture that make this very difficult. One word is government, and the other word is taxes. Taxes. And when people hear any variation of this, it's the government's going to run my health care. I don't trust the government. I don't want the government in my business, that whole line. And somehow this is going to have to be paid for, and it means I'm going to have to pay taxes. So how do we rebut those two concerns, government and taxes?
Okay, well, so now, you're worried about, if somebody's worried about government controlling their health care, would you prefer to have the insurance company making those decisions? A for-profit insurance company at that, who's already said that their obligation is to increase earnings for their stockholders. So is that going to get you the best value? Maybe not. So also I do look at a program like Medicare, which has really done a good job for Americans. At the time before Medicare was passed, older Americans were faced in poverty, faced for the potential of lack of care, and Medicare really turned that around so that you don't see a lot of people who would be happy with getting rid of Medicare. And this is, of course, one of the reasons why we like to envision the single-payer system as an improved Medicare, an expansion and improvement of Medicare. But it is huge government. It'd be a huge, in New York State, we're talking about putting a huge amount of money through a dysfunction, what has been called by some a dysfunctional sort of government. And you worry about corruption and so forth. We can't turn that money over to any kind of state agency without a lot of safeguards to make sure that it's well used. And I don't want to suggest that we should. Government and taxes. When you pay an assessment for the New York Health Act, as an example, you don't pay insurance premiums. So that there's a trade-off there. And for lots and lots of people, particularly at the lower end of the income, it's wildly in their favor. It's a highly progressive piece of public policy, this New York Health Act. The people who do have to pay more people are the top 2%. People above incomes of about $250,000 a year. And see, I kind of think that those people have less trouble paying a $25,000 healthcare premium than somebody who's earning $50,000 does. Okay, so when you're thinking about taxes, we're transferring the payment instead of having. We're going to collect more we're gonna collect payroll taxes and taxes on earned income, but that's in place of out-of-pocket expenses and in place of healthcare premiums.
I'd like, and you just touched on it, George, the employment, what happens to all those employees from the private insurance companies? A lot of those employees are claim processors, and the new program's gonna need claim processors. So they'll have the same job, just a different employer. The other thing is, I think any Medicare for All universal health care system has to include our elected officials. To date, they have been able to opt out of many of the social programs that the rest of us don't have the choice to opt out of, such as Social Security, Medicare, and other payroll taxes that pay for social programs. And I think part of the problem is that from the get-go, we let them opt out, and so they don't have a vested interest in this because it does not affect them personally. So I think any legislation we do has to be inclusive of everyone, elected or not.
I certainly agree with that. This would be a universal health care insurance. Everybody in, nobody out.
Would the single payer system that was state specific, say New York State specific, necessarily still rely on receipt of federal funding? And if so, do you see there being certain vulnerability there in terms of the what we may have to fear would happen in that regard?
The federal funding is critical to the New York Health Act. There's no question. It's critical. And in order to get those federal funds into the trust fund for the New York Health Act, the health program, there would be required federal waivers on those programs to let those funds fall into that the New York public program. Those can be done. Talk about some of the difficulties in the political realms in Washington right now. And I consider that's going to be another struggle. I can't see it getting around it.
Personally, I fear that, the healthcare in Mississippi.
Speak up, Andy.
Healthcare in Mississippi and Louisiana, some of the Southwest, really shocking disparities. And I would really hate to see some kind of a states' rights, Medicare for All in New York, and no public health programs of any type in Arizona. I think that would be a terrible disaster for the country. So I really feel that it really should be everybody in, nobody out, and we should just stick to that principle and fight. And there's going to be compromise along the way, but again, I don't see a need for starting with a compromise. And just on the taxes and the government, there's a great deal of breastfeeding about firefighters, paramedics, policemen, anybody in the armed services. In other words, there's a consciousness that there's such a thing as public service and that it's honorable. There already is that consciousness, so I don't know why it would be such a leap to think that we should have public service. And when I started this whole project a long time ago, Dr. Alan Chartock invited me on the radio to take calls, and I was extremely nervous. And sure enough, the third caller said, "Aren't we really talking about socialism?" And I didn't get to answer the question. Alan said, "Yes, sir. Socialism like the interstate highway system. Socialism like your public library. Socialism like the post office. Next caller."
That's so
I have a certain affection for Bernie Sanders just because he was willing to identify himself as a socialist. And we've all been a little desensitized to that word because it got used so much in public, and that was a service to this country.
We're near the end. We should be one more. A little longer. Yes, sir. Okay. Everybody's put up with us for 2 hours.
Let's assume for a moment that we get a single payer. It seems to me that there would be a
larger universe of people eligible for medical care. And I think that most of the single-payer systems focus on prevention versus the last six weeks of your life as far as what care is provided. What changes in the infrastructure of hospitals versus clinics versus whatever, and the personnel would be changing, and how would that change? And one last question is, why haven't we gotten something that's a version of like TurboTax or H&R Block, where a person sitting at home could plug in what my personal circumstances are and get an answer at the bottom of what the cost to me would be.
The campaign for New York Health has been working on that kind of TurboTax thing to show what that person's consequences would be. I'm not sure where it stands right on that right now, but that people have been thinking about that.
What about the change of how?
Oh,
So in terms of this demand, our reform that we talk about all the time is such a skinny, tepid increment of change. It is not a proposal for delivery system reform. I wish it were. I think it gives us the lever to reform the delivery system. For example, to say that it's outrageous that the ER is oversubscribed with patients and there are gurneys on the floor and every hospital has to prepare for the surge, not prepare for the need. But we would have the lever for those changes because all the money would be in the public pool, and the public would have a say-so over how the resources should be spent.
Is it clear when Andy said that it wouldn't change the system of delivery very much? This whole thing is single payer finance. It's not delivery of medical care. It's
not service.
Doctors and hospitals and so forth would continue to deliver care. This is going to be paid by one payer, right? That's a really important distinction.
So it's just an increment of change that gives us opens the door to begin to change the delivery system, for example, to begin planning. We don't have, this is harsh, but we don't have serious community level planning for health needs in our country. It's shocking to think in the 21st century, with all of the public health science at our disposal, we don't use it for planning. We plan for the next quarter based on the financial statement of the biggest institutions. And so if all the finances were in one public pool, then we'd have the beginning of planning. Similarly, we're not proposing to nationalize the pharmaceutical industry, as much as I think that's a good idea. It would simply be an oblique threat to the pharmaceutical industry that you guys are going to have to bargain, and we might even have the power to make you do some science that you don't want to do to prove, like, for example, which particular medicine is right. So it's a very, very skinny reform, which is part of why, I kind of like bristle at the idea that we should take this little increment of change that we're talking about. Well, yeah, it takes out the most parasitic portion of finance capital, the private health insurance industry, and says that's not a legitimate way to make money. Go make money some other way. So it's big on the sense of its impact on very powerful, very wealthy people. It's big on its impact on the liberating side it would have for poor and working people because they wouldn't have to worry about health care. But in terms of a policy change, it's a very little teeny policy change that is totally doable. And the strongest thing about it is that it will work. And the strongest thing about it is it can be easily done. Medicare was enacted and implemented within a year using postcards in the U.S. Postal Service. Everyone got enrolled. There was not a crisis of oversubscription. People didn't sink the system seeking their colonoscopies. That's what I mean? It worked. It worked. And we have other experiences from other places. This can work. But it's in terms of the demand, you can overestimate the demand because of its threat against the powerful. You can overestimate the demand because it would liberate poor people. But you can also underestimate the demand because it is so doable. It is eminently practical. And that's what makes it so compelling, is it has this fantastic character of social reform. It would actually be built up, it would actually cushion the poor. You know, we have this real problem of poverty right now in this country, and I see it in the hospital. This is my conclusion. In the hospital, human experience comes to us. We recently had a man who was dying, he knew for many years that he would die of colon cancer. But his children never quite reconciled, and he and his wife didn't really live together anymore. When I met his daughter, I told our social worker, this is one of the hardest cases I've seen because this is going to happen like soon. And no one's on the same page, and no one's ready, including maybe the patient. And as you learn the social details of family life, you see, you know, the little aspects creep in. And you get to know people in an intimate way. And it doesn't spare the wealthy. And we have an overpopulation of the poor who have many times illnesses that are untreated. And what I'm starting to understand is how shockingly poor the poor people who are our neighbors have become in the last couple of decades. And the unbelievably meager resources available to a household that are forcing many generations to live together. The incredible social insecurity of trying to hold one job or one part-time job. And of course, the incredible psychic pain that comes then with alcoholism and opiate dependence and all of the crises that we see. So you begin from the inside of the hospital to think that you're living in the middle of a boiling crisis because of the intimacy that you have as a privilege of being a physician and hearing why the patient has come and what's happening in their life. It gets to be very compelling. But it also weighs on your conscience. And I think the end of it is, you know, what kind of country do we want to live in? What amount of indignity will we accept, like Frederick Douglass said at the beginning? And what can we do to change it? And that's why this little, teeny, workable reform, far from a huge cultural change, it just is a lever for the future, I think is so important and so achievable. So that's my question.
Most of the people that joined the huddle last year have never been active in politics or anything else other than the usual. And we all got together and we've met consistently. We have 6 or 7 issues that we're working on besides healthcare. We are working on voter registration, changing the voting laws in New York State. We have a group working on justice. We have a group working on gun safety. If you're interested in moving these platforms forward in some way, we welcome you to join us on these meetings.
Did you say you meet in Delmar?
In the Delmar Brugers right now. They have a little room on the side, and that's our meeting place. We have half the room right now, so we may have to move on if we get